There we go. Welcome everyone to, I'm calling it the end of the summer Friday Facts. So exciting. We're ending with a blast. That sounds sort of wrong, but I'm really excited. I'm so excited to have Emily and Dean here. It's a great get. Our really engaged members this year with the Serious Illness Coalition, and there's so much to learn. I know they're going to talk about the North Carolina Healthcare Foundation, the North Carolina Healthcare Association, and I'm
What?
letting other folks in. So I want to welcome Dean Higgins. Oh, all right. My internet connection might be unstable. Can you still hear me okay?
We can hear you now. Better.
Okay, great. Well, then I'm going to let you take over before I do anything else messed up. But we have Dean Higgins, Executive Director of the North Carolina Healthcare Foundation. I'm doing multiple tasks, also letting people in, joining us. And we have Emily Roland, the Senior Director, Program Implementation for the North Carolina Healthcare Foundation, and the North Carolina State Team Lead, CaroNova. They have a presentation, and I'm a little worried with my own internet all of a sudden acting unstable. So I want to turn it over to them. They're going to talk about their work, but I also would love for each of you to take a moment to just introduce yourselves. We have a lovely history here on Friday Facts to share a bit about your own background and what brings you into this work. So I know you have slides, but take it away, Emily and Dean, and share a little bit about yourselves as well as your slides.
Emily, you want me to go first? All right, good morning, everybody. Happy Friday. Thanks for Heather and team. Thanks for inviting us. We're very happy to be here and engaged in the Serious Illness Coalition. So I know some of you all, but my name is Dean Higgins. I'm the Executive Director of Program Development Operations for the North Carolina Healthcare Foundation and one of our strategic initiatives, CaroNova, which we'll talk about. I know that's a mouthful. Just a bit about me and background and kind of my path to where I'm at now and the work we're doing. I started my early career in community mental health. Was very passionate about that work, working in the Ohio, Cincinnati, greater Cincinnati area. Community-based programs with adults with severe mental illness. Was very where I met my wife. So it was a good career move and very much passionate work for me. And then transitioned to working in some small community-based hospice programs in the Cincinnati area as well, both in developing volunteer programs and then also doing some kind of community development, business development for a few small kind of startup hospice programs in the Cincinnati area. So again, it's still in healthcare, but a different aspect of healthcare, and again, very passionate about hospice, and that's why I'm so excited about the work we're doing in serious illness and standing up some of these palliative care and expanding palliative care services across the Carolinas. Came to North Carolina from Ohio in 2008-9. Decided I would follow my wife to grad school at UNC, so that also was a good career and family move for me. And then that's what led me to NCHA, the North Carolina Healthcare Association, back in 2009. And at that time, the work that I was doing was under what we branded as the North Carolina Quality Center. It was one of NCHA's, and it was pretty forward thinking for the time. It was earlier in the quality and patient safety movement nationally, a lot of work at IHI and just national focus on harm reduction and patient safety within healthcare. So it was a very exciting time to be working on a lot of hospital-based clinical harm reduction programs, large scale improvement, what we call collaboratives, and again, just providing programming and technical assistance and coaching to mostly hospitals that were working collectively to work on surgical safety, care transitions, which is where Heather and myself and several others on the call had met through some of those coalitions around, which we branded as NC Act, was one of the Duke Endowment funded care transitions collaboratives and just kind of coalitions, which was I think where I met a lot of folks that kind of through the Serious Illness Coalition. So a little bit about me, and that's where we're at today is what we'll talk about, just the work we're doing and the kind of the evolution of the work at NCHA and our foundation and our work today on serious illness care. So I'll turn over to Emily.
Good morning. I love that chance actually to hear all of Dean's background, because we don't always get the chance to kind of dive into that on the day-to-day work. But great to be here and nice to see and meet a number of you all. Again, as Heather mentioned, I'm Emily Roland, and I'm the Senior Director of Program Implementation for the Foundation and the North Carolina State team lead for CaroNova. And as Dean mentioned, we'll kind of describe how all those things are related here in a little bit. A little bit about my background. I'm a North Carolina native, which sometimes feels a little bit more rare these days because we've got such a great melting pot of tons of folks from all different parts of the country here in North Carolina. But I was born and raised in Greensboro, North Carolina, and went to school in Chapel Hill, and then slowly made my way here to the Triangle. So my kind of career background, I did spend 10 years working at the Leukemia and Lymphoma Society, really starting my career there, doing donor development and program planning for them in a number of capacities, kind of on their main fundraising events. Have always had kind of a passion for cancer and cancer awareness. Did not have, unfortunately, the ability to jump into healthcare on the clinical side. That was not a strength for me, but always really felt passionate about getting involved in healthcare and supporting patients and families, and making an impact kind of on the programmatic side. So again, began with the Leukemia Lymphoma Society, worked with a lot of families and organizations and companies, but also a number of healthcare institutions and systems, and sort of made a transition at the end of being there for about a decade. Really was kind of seeking a change to kind of expand my horizons, and connected with one of our hospital members that was involved with the Leukemia Lymphoma Society. And they encouraged me to look at an opportunity at the North Carolina Healthcare Association. So at the time, we were the North Carolina Hospital Association, now the Healthcare Association, and began my role just about 10 years ago as well at NCHA. So stepped into the work at NCHA on our advocacy and policy team. Now my role is in the foundation, but initially it was on the association side, doing our grassroots advocacy and really starting our grassroots advocacy program. As you all, I'm sure, understand, it kind of becomes increasingly important for our hospitals and health systems, and really, any providers and organizations across the state, to make sure that the issues that they're experiencing in their communities are really understood by our lawmakers. And ultimately, that's where we're going to see sort of that sustainable change. So I took the kind of skill set I had building relationships on the donor development side, and transition that a bit more to that advocacy policy space, and really had the opportunity to travel around the state, which I loved. Again, a huge passionate North Carolina fan. So it was really fun to actually get to explore all the different area corners of our state, especially our rural communities, and really learn a little bit more about what the hospitals and health systems look like in those communities, what their priority issues were, and how they were engaging with their communities to talk about these issues and the impact of the hospital and health system in those communities, and what that meant from an economic development lens to a community health improvement lens, how they were, really partners in their communities, and how they were telling that story with their again, various partners in their communities and to lawmakers. So really enjoyed that work, kind of mobilizing that advocacy voice for our hospitals and health systems. And then an opportunity came when we were sort of reestablishing the North Carolina Healthcare Foundation. We've got a long history at the association since its initial kind of founding. But we had an opportunity, I guess it's been about 7 years ago, where we were really reestablishing what the foundation meant to the association, and how we could really leverage it as an opportunity to accelerate innovative work between hospitals and their communities. And Dean, as he described, kind of a lot of great history around the work that the foundation has done, and just felt like there was more there that we could be doing to build on that strong foundation. And so found an opportunity to shift my work from just the grassroots advocacy space to really supporting that community hospital partnership around program implementation, to see community health improvement. So as we all know, those things are sort of all intertwined, right? Because community health improvement is where the kind of that rubber meets the road to really see where individuals and are seeing kind of hospitals involved in how they see health beyond just the clinical care. But then when that work happens, they also become really strong advocates about the value of hospitals and health systems. So that those things are kind of all together, and ultimately we sort of saw those things intersect. So really have loved the work in the foundation and being able to see really kind of boots on the ground what hospitals and health systems are doing around community health improvement across the state. And then seeing that in our CaroNova work with serious illness care. So again, we'll pivot in a little bit back over to how we kind of talked about serious illness care as a topic. I will say a little bit of my background on that topic, kind of organically. I mean, I've been, as I mentioned, have a passion for kind of cancer and cancer care, experienced kind of seeing my mom battle breast cancer for a number of years. And then she passed when I was a young teenager, but was exposed to kind of having access to palliative and hospice care was just a critical tool for our family. Was a choice that I felt like we were given in a time we don't have a lot of choices. Was a choice for support, and they had hospice come into our home, and was just a tremendous comfort to our family. And a number of family members have volunteered for a number of years on the hospice side of things, just knowing how important that resource was for our families. So definitely have experienced firsthand how important that work is, and I felt like when we had the opportunity to do the serious illness care work, have really been passionate about what that could mean for patients and families, and now been able to learn a bit more about the programmatic side of that. And then the final piece I'll share is I did get my master's in public health somewhat recently, which was exciting. And then during that time, had the opportunity to dive into some of the foundational aspects of hospice and palliative care as well as part of that effort and how that's delivered. And so I was excited to kind of learn that in my school experience too. So anyway, excited to be here and passionate about this work. And thanks for letting us share a little bit about that.
No, there's so much. I have follow-up that I would love to dive into the two of you more, but I'm holding off. I'm even holding off on my questions because I know that you're about to do a presentation. You have some slides, so I'll let you go through them. Folks, if you have questions, feel free. I'll keep the chat going and let them know if any questions come in, because I'm already starting to think about the different initiatives. You gave little appetizer bits of, you kind of threw out, well, there's the foundation, the group of hospitals, your programmatic work, CaroNova. So love to hear more about it. And I did want to highlight that in many communities, the hub of community health is the anchor, is the hospital. And so it's exciting to see in our state, the hospitals taking that responsibility even broader. So with that, I'll let you share your slides.
Great. Well, I will jump in. Dean and I have worked well as a tag team on a number of the facets of the serious illness care work. But as Heather mentioned, I'm going to attempt to share my slides. So if y'all be patient with me for one moment and let me make sure I'm pulling up the right thing. If you all can see.
It's a bit of a Captain and Sneal routine we worked up here this morning. So just without the outfits. So our low budget Captain and Sneal.
And are you guys seeing? Oh, no, you're not seeing my screen. I haven't pressed share. Are you guys seeing my screen now?
Yes.
And then I'll put it in
slideshow. Yeah.
Presentation mode. I can find that. And is that the correct screen?
No, that's the speaker presentation mode. So you want it's funny when we.
Here we go.
Checked it out before. No, there we go.
There we go.
Great.
Dean and I have, as we're getting into the serious illness, or have been in the serious illness care space, we've, been continuously building some tools to really talk about this work. So glad to leverage some of those today. But just wanted to start here. I'm going to share a little bit, and then Dean will fill in all the gaps that I know I will leave as well. And then he'll expand on some of that as well. But just wanted to provide, again, that sort of framing about how our different organizations are related. Shared a little bit about the North Carolina Hospital, and now the Healthcare Association. It was formerly the Hospital Association, which, as you all might be familiar, is a trade associations for hospitals and health systems and other healthcare providers across the state. And the foundation is really the 501c3 arm of the association, where we really have an opportunity to leverage those grant dollars to do some really innovative and programmatic work. Again, boots on the ground, really within hospitals and in that intersection point between hospitals and communities. And ultimately, our mission for the foundation is to have hospitals and communities collaborate to really see that impactful change around community health improvement. And so we have 5 kind of core areas of work within the foundation related to access to care, rural health, workforce, behavioral health, and equity of care. These really kind of are similar buckets of work with our association, but we just kind of approach those topics on slightly different sides of that coin, and then bring that work together. So I would say the serious illness care work, and I'll jump into kind of what CaroNova is here in a moment, but really kind of falls in a lot of these buckets, but definitely, is a critical component of kind of each of these core areas of our work. And then our grant making strategies for the foundation, kind of this is just it's a high level. We're really aligning the funding priorities of our healthcare and hospital systems with the community needs. So using data to see where we're seeing gaps and where we can effectuate change. There's a lot of organizations involved in great work across our state, and we want to identify kind of where our unique value proposition is to get involved there and bring those and bring opportunities together. We have TA and evaluation that we provide. So when we're implementing programs, we're able to support those programs to be successful. And then we, again, as mentioned, we're leveraging grant opportunities, and that includes private and government funding to really to see change and to pilot new opportunities. So to explain a little bit more about CaroNova, I mean, historically, the North Carolina Healthcare Foundation and the association has had, partnerships with other hospital associations and the Duke Endowment, but this was really an opportunity to come together in a more collaborative fashion with the South Carolina Hospital Association and the Duke Endowment as an anchor funder. And so this is really kind of a really strong partnership where we found that there was an opportunity to bring payers, partners, patients together at a common table to really implement sustainable change. And sustainable when we're kind of considering how do we need to address policy change and payment mechanisms to support health improvement. And we saw some really great opportunities here. So, this slide gives a little bit of a background there to how we're bringing those different parties together. The intention is to implement low-risk pilots. So with the Duke Endowment as an anchor funder, we see there's a gap between how current services in different ways are paid for and how those services are being delivered. There's a gap there that the Duke Endowment is kind of willing to step in and fund through grant dollars, but the intention is those grant dollars fill that gap while we bring payers and providers together to establish kind of value-based contracting that will support that work moving forward in a more sustainable fashion. So if we can change the payment models moving forward, the grant dollars aren't going to be needed, but the grant dollars are there to sort of build a foundation for how payers and providers are collaborating initially to see initial change. So that was sort of the impetus of CaroNova, sort of bringing all those partners together at a common table at a place where we see that there is a need for change, but maybe not the incentive or the ability for one entity to kind of take that step forward. We felt like CaroNova had an opportunity to kind of take that step and kind of begin that process. This is just a quick overview of kind of the steps around the CaroNova process and big buckets. We're cultivating is around identifying what the needs are and bringing everyone to the table to identify what those needs are and where the gaps are. I'll talk a little bit more about that in a moment. With the serious illness care work, we knew there was a lot of great work already happening in the state, but we wanted to find out kind of, again, where the gaps are, where do we provide a unique role, not to be duplicative. Co-design is really around bringing all the parties to the table to figure out those solutions. We're not going to be figuring those out in a silo, but that's really where we are leaning on experts across the field to help co-design what that looks like. And catalyze is really around that sustainable change through policy or payment reform. Um, and serious illness care was really a topic that was brought to the table initially because the Duke Endowment was seeing a number of funding applications for some really incredible programs around this topic, but really wanted to identify how those things could kind of come together and how we're looking at, again, that sustainable solution that we needed to develop around addressing some of the gaps that seem to continue to exist. And they wanted to sort of begin to move out of a space of just programmatic funding for kind of grants year over year and see if we could really address the issue at a systemic level. And serious illness care was a place where they were really seeing the majority of, I would say, a lot of grant applications coming through. So they were seeing a lot of interest in this field. As we know, kind of the population need. I know this group is very familiar with that. So this is a couple of statistics there, but saw this as a place to really begin some work with CaroNova. And so we spent a significant amount of time beginning in 2019 understanding the work that was currently happening and where the gaps were and where we could engage. We did an environmental scan with our research and evaluation team to really pull the research that's out there, to understand the local data that's out there, and really to conduct stakeholder interviews with all of those who are involved in this work, a number of you all, of course, being a part of that group. We started involvement with the Serious Illness Coalition here, as well as in South Carolina during that time to better understand kind of, again, where the gaps exist, and then help to pull together and identify some of the partners that we wanted to, that have the desire and the interest to kind of come together and help us shape how we were going to approach this work. And then we secured support from our advisory board to kind of move forward in that space. This is just a quick kind of reflection of that this is a core part of how CaroNova approaches our work really in a patient-centered way, because we do this kind of patient journey mapping initially as we jump into any topic. We really want to, again, bring together patients and their families to understand what does a current topic look like and where are they experiencing barriers. And so, again, just a reflection of kind of where we saw those gaps illustrated here from a patient and family perspective. And we kept a patient and we have kept patients and families kind of at the table during the co-design process as well, and are now, during our piloting process, identifying opportunities to engage the PFAC at some of our pilot sites to continue to explore, the impact of what this looks like, really on the front line with patients and their families.
Yeah, just a quick plug for the artist who did this. A Visual Approach is a small service, I guess, company, nonprofit, based on Durham. And Hope, and I'm struggling with her last name, Emily, you may know, is the artist kind of facilitator who did this. And they do just really cool live mapping and these great visuals. If you've done like a planning session, or if you were bringing together stakeholders to map out what does a problem or an issue look like, it's a great way just to live during some sort of facilitated session to kind of create these really cool maps. So I'll just quick plug for that group. We're not tied to them. We just used them several times.
That's a great point. And so I'll actually pass it over to Dean. I feel like during this exploratory phase is where we kind of identify these current realities of serious illness care work that informed the framework that we built for the comprehensive palliative care for serious illness pilot. So I'll pass it over to Dean to expand a little bit more there.
Yeah, thanks, Emily. And I'll try to go quick because I only have a few minutes, and then Heather, if there's questions, we can stop. But so this really pivots into, based on that landscape analysis that what Emily describes as that cultivation phase, what do we discover? And again, probably no surprise to this group that what are those gaps and opportunities that we're trying to address through piloting and larger demonstration projects. And it's what we talk about, like the identification of patients. So on the provider side, like, are we having those conversations to identify patients that are eligible and would benefit from these services earlier and further upstream? And then, connecting with those patients and families in the community so they see the value and understand what palliative care and supportive services is and what it means. And it's not end of life care, it's not hastening death. It's all those conversations that we've been trying to have, crucial conversations. The and then just the current system, how it's set up and reimbursed, that we know that there's a lack of adequate interdisciplinary coordination, poor continuity of care really across the continuum of, community-based care to acute care, post-acute care. So really trying to provide that coordination and incentivize that coordination. How do we train providers and educate providers, and some of the discussions even further upstream, medical students and others that are entering healthcare, to have these type of conversations around advanced care planning and goals of care. Of course, the payment model that incentivizes this level of coordination. And then, as always, the role of the family, the caregivers, the informal caregivers, in being part of that care team, and really their needs being considered as part of the treatment plan. So just trying to wrap that all up into what we consider the framework on our next slide. And this is really the framework that we are aiming for as we think about what are we trying to pilot and establish, and we're trying to create a sustainable payment mechanism to support this level of coordination. So really starting with having a very clear patient identification filter, using well-vetted inclusion criteria that says which patients are eligible, and creating systems and workflows that help providers and payers identify those patients and get them connected to services. And then, of course, looking at through the continuum of diagnosis, through living with serious illness, to end of life care. What does that continuum look like? How do we layer those clinical services with those other supportive services? Again, really aimed at both patient and family, and then creating some structure, some operations, staffing to really make sure that it works effectively. So a lot of what we're trying to do through this grant program is utilize the grant funds to fill the gaps where providers, both health system based, but community providers, may have that make it difficult for them to do this this kind of more comprehensive framework of palliative care. So on the next slide, we talk about the what is the opportunity. So we're again trying to pilot this what we say is comprehensive community-based, so palliative care everywhere. So whether it's inpatient or in community-based settings, or really across the Carolinas. And again, back to addressing those gaps of having standardizing the criteria that really incentivizes those earlier conversations and identification, creating the minimum standards of care and operations for patients and families. And so the minimum standards that would be used for value-based contracting, creating the really validating the business model that provides the incentive for payers and different types of purveyors, so payers, whether it's commercial or Medicaid, or even working with CMS to again create that business case and support the business case for new payment models. And then what we think is really critical is to our model is having both payer and provider at the table, and really doing it in a co-designed fashion. So we started that in South Carolina, and we think having that kind of that payer provider collaboration with CaroNova as kind of the broker is critical to our success. So on the next slide, so we talk about our pilot approach a bit further, and this is just kind of the framework of how we're thinking about this. And I see we're at the end of the time, so I'll just say quickly that we're using kind of 1 to 2 year kind of grant, 1 to 2 year kind of grant framework to say, how do we provide some technical assistance and framework to help build out clinical operations, build out workflows, how to earlier identification, and then using a really robust data and evaluation infrastructure, say, yes, we're doing good work, but we need to be able to kind of prove that and validate it with data that we can then take back to the payer and say, here are the outcomes, here is the impact of when we're comparing patients who aren't getting this level of services to those that are going to the program. And that's what the payers need to say, or if we're going to change contracts, we need that level of data and evaluation before we're willing to do that. So that's why having that level of data infrastructure is critical. The last thing I want to say, we're seeing this as really a multi-year, 4 to 5 year trajectory, where we're starting small, 1 hospital, 1 payer, started in South Carolina. Now we're just now at the point this past few months of establishing a similar pilot in North Carolina with 1 payer, 1 provider, learning a lot, validating, and then we're going to scale that, where by the end of our goal is next year to get into like a larger scale demonstration project where we can do an open RFP where multiple providers can apply to be part of this larger demonstration project. And then we'll continue to provide that data and evaluation support and some technical systems and coaching to support them in those efforts.
Mhm.
So I'll stop there because again, I know we're at the top, or actually we're over the time.
Oh my gosh. So this was so good and rich that it was actually sort of mean. I think we did like the meanest teaser because you threw out so much great information so quickly, and we need another hour. In fact, there's already a conversation about how do we get this in the symposium or longer meetings to really dive in. So everyone, this was your Friday appetizer. A few questions, and may this be the first of many conversations. We've had one or two times multiple part one, part two, part three, and that's definitely going to be happening with what's going on with the North Carolina Healthcare Foundation and specifically CaroNova. A few questions. Can folks use some of these? You did amazing illustrations. I say on when you mapped out the issues of serious illness care, if you could slap your logo on it, and then can others of us use it with attribution? I think there was the request there. Can some of us, use these slides in other ways, but attributing?
Absolutely. Yeah, we're happy to share in any way. Like there's this is a community, so we steal shamelessly and we expect others to do the same. So
Fantastic. That's why I was like, feel free to put I know years ago when we did a care transitions one, we saw it in someone else's presentation, but they did do an attribution. So we're like, okay, that's cool. And then, and Emily, thank you so much. Just put some links to the work about CaroNova. I love the question that Deborah posed. Is there a way to sign up to be getting emails and updates on this work? For those of us that are not part of hospital systems, so we're not already part of the Healthcare Foundation. If not, you can use our listserv.
I'll say we don't currently have like a newsletter specific to this comprehensive palliative care for serious illness pilot, but we do. I put a link in there there's a contact page, contact request page for CaroNova, and we do have periodic newsletters around just generally the CaroNova work. So I think that would be a great place where we'll be sharing kind of ongoing updates about not only this pilot, we're doing work with youth mental health and workforce, and so a few other areas, but definitely we'll include this.
Okay, that's great. And really, I, send out 2-3 times a month updates to the membership. Feel free to give me, paragraphs or blurbs or something, and I can add that in there. Are there any other questions that I'm seeing from the chat besides thank you? This is really helpful. And again, let this be the beginning of more conversations. I do want to give a shout out to Dean and Emily. They have been working behind the scenes with myself and Ellie Ward and one of our summer interns and then interns last spring to help to move forward the serious illness conversation training for providers and students. Because as you saw in one of those mapping, providers aren't comfortable or haven't had the training to really have thoughtful serious illness conversations. And so I love that the work of the Serious Illness Coalition is aligning so nicely with the work of the foundation and CaroNova. I realize we're a little bit after. Any other quick questions that folks want to ask? Yes, Karen.
I was looking for the reaction button and I just decided to do the old fashioned. Thank you both. This was incredibly enlightening and kind of, I got a physical reaction about it, especially as I mentioned in the chat. As you may or may not know, Heather and I are working on I'm with the North Carolina Caregiving Collaborative, and we're working on a grant that we are doing with the National Alliance for Caregiving, and having you acknowledge in your work that caregivers are not included as part of the healthcare team often, and in fact in treatment plans, is huge. And it's one of the goals of our group, because what the National Alliance for Caregiving is working on now, and all these grants that are going out to different states are working on the implementation of the national strategy to support family caregivers, of which one of the goals is working harder on including caregivers as part of the care team. And so I just already signed up to get more information on the website, because I feel like we can bring this to that group to say, you know, especially in North Carolina, we're working specifically on the North Carolina side. So I can't wait to hear more about what you're doing in North Carolina so we can bring it back to them to brag a little about our state. So thank you.
Mhm.
Yeah, you're welcome, Karen.
All right, well, gratitude. I know we need to end, but really, this is the Casablanca, right? It's not even the beginning. It's the continuation of a beautiful friendship. But really, you're doing excellent work. This is inspiring on our Friday, on our last Friday facts of the summer, I call it. We have some great Friday facts planned for September with Trish Farnham, Essential Jobs, Essential Care. September is Sickle Cell Awareness Month, and we have Sickle Cell Partners of the Carolinas. So thank you so much for coming on Friday Facts. Thank you so much personally, because Dean, you and I have worked together, gosh, for what, more than 15 years now, I think. But also your involvement in the Serious Illness Coalition has been so, so helpful. And your work with our work groups and our special projects, and the rest of you are getting a sense of the depth of the support that you provide and the information and the perspective. So
Well,
with that, happy Friday, everyone. Yes, Dean, sorry.
No, I just want to say thanks for having us, and
Yeah.
we've also learned a lot from the coalition, and we get a lot of value out of it. So thank you all for like teaching us and